respiratory failure, there is no absolute contraindications for ECLS. But yes, if a patient is on a mechanical ventilator in high settings for a long time, 7 to 15 days, this patient's lung is quite destroyed. So such a patient is when you want to start your ECMO, you want to start it fast. Within 6 to 8 hours, if you feel we have done everything possible in the RDS settings and the patient is not improving, you want to put the patient first. If the patient is immunocompromised, that is neutrophil count less than 400, because you got so many tubings and everything, the chances of infection are very high then. A CNS hemorrhage patient already has a brain bleed, which is recent or expanding, because you are going to be using a lot of anticoagulants in the circuits. Non-recoverable co-morbidities, such as major CNS damage or malignancy. So basically, contraindications are prolonged ventilation, or patient is immunocompromised, prone to infections, or he already has a bleed or likelihood of bleed, or he has some major other end organ damage already. Now for cardiac failure, inadequate tissue perfusion, which is manifested as low BP and low cardiac output in spite of everything you have done. Shock is persisting despite volume administration and inotropes and IABP if appropriate. So what are the causes of these kind of shocks? You have MI, you have myocarditis, you have post-surgical cardiotomy shocks, or you have septic shock which can cause a cardiomyopathy. So these patients are also very good candidates for ECMO. So ECMO in these is a bridge to recovery. You have to understand it's always a bridge to recovery. So acute MI after revascularization, or you're waiting for transplant. So or implantable circulatory device where you have a ventricular assist device. So you have some definitive treatment again waiting for him. So then ECMO is useful. Contraindications is unrecoverable heart, or patient is not a candidate for transplant, or he has some other organ dysfunction, end organ failure. He's a cirrhotic patient. He's got renal failure already. Such patient is not going to really improve on an ECMO, or he's got a prolonged CPR where we don't know the status of the brain. A relative is obesity and advanced age. So like when you have a patient of ARDS, if the PO to FiO2 is less than 150, we strongly recommend proning. You can give neuromuscular blockade, PEEP. You can do all recruitment maneuvers. If you have tried all of these and the PO to FiO2 ratio is still less than 60, greater than 6 hours, then you would consider for ECMO. Then you decide whether there is a contraindication for ECMO. If there is not, then you do the ECMO. If there is not, then you try something else. So the whole thing is